Hello everyone. So I welcome you all back again to all the physio friends and family out there. Thank you for being a crucial part of our PhyX pain solutions, and today we are here with more than 1200 registrations, and that is possible because of you. So now today, taking the continuum forward, we are moving towards the next topic that the poster said, that is the lumbar assessment, and specifically targeting on the palpatory aspect of the same. So this video is meant for anyone who's aiming towards, mastering the palpating skills at the lumbar spine. So before targeting and before discussing all those areas, I would like to discuss with you what all things lumbar spine encompasses within it, and what all things you need to do, and what all types of issues a person can present with. So we'll not be going into detail of the pathology of the lumbar spine, but yes, I'll be discussing the assessment part and the palpatory aspects you need to take care of, and with the surface markings on a live subject. So it's a live hands-on demonstration. So don't worry, just stay tuned and keep on watching, right? So let's start with it. First and foremost, let me talk about the lumbar spine. So as you people might have read in your books, textbooks, that they say that lumbar spine is a secondary curve. What does that mean? So secondary and primary. So it is a secondary curve, that means there is a primary curve as well. Yes. So we have the kyphotic spine, actually kyphosis at the thoracic spine. Okay. So that is the primary curve, and the lumbar and the cervical spine are the secondary curve. What does that mean? So if you look a person from the side lying position or side standing position, so what you will see is there is a curve. So cervical spine is like this, C-shaped, thoracic spine is like this, C-shaped, and lumbar is again like C-shaped. So these three curves are because of a particular reason. It's not like it developed all of a sudden. Yes. When you see a baby in the womb of a mother, you'll see that the baby is like this, curved, completely kyphotic. Okay, completely in kyphosis. So how does the lumbar and cervical lordosis develop? When the baby at the age of 3 to 6 to 9 months, when he starts taking his neck up, so when the baby is in prone position and he starts maintaining the control of the neck muscles, so he starts extending the neck upwards. So what happens is there is an extension of the cervical spine that leads to increase in the lordosis at the cervical spine. Likewise, when he starts extending at the hip region at the lumbar spine, that leads to the lumbar lordosis. So these are secondary curves that develop after the birth. That is, that develop after the gravity acts on the body and the muscles control the movement of the body to counter the effect of gravity. That is when the lumbar and the cervical spine curves develop. Now coming to the lumbar spine anatomy, a bit of biomechanics and how the movements happen. So talking about the lumbar spine, in the lumbar spine we do have certain parts. If we look at the lumbar spine, we have L1, L2, L3, L4 and L5. So we have 5 lumbar vertebrae. L signifies the lumbar thing, right? Now L1 to L5. So we have 5 in totality. Now out of those 5, what we need to do is we should be very much focused about what all things are there. So there's something common in 5 of them, and that is the structure of the lumbar vertebrae. That is why they are characterized and they are placed in a sequential fashion. Like in the spine, we say this is cervical spine, this is lumbar spine, this is thoracic spine. Why? Because every particular theme, that is lumbar, have something in common. Cervical, all those 7 bones have something in common. That is why they are differently distinguished. So likewise in the lumbar spine, we have a structure that is common in all 5 of them. That is the front part, that is the body of the vertebrae, has something called the intervertebral disc above and below it. That makes the intervertebral disc that takes the weight of the body, the cushioning aspect of the body. So along with that, behind the thing, there is a ring shaped structure. So the front part of the ring is formed by the body of the vertebrae, right? Then comes the pedicles. Then at the back side comes the lamina. So lamina and pedicle make the round shape, and then the spinous process at the back. So if you feel right now, just place your hand at your back, at the lower back, you will feel some pointing, 5 points, 5 sharp edges coming out. That is what we call the lumbar spine. Now talking about the lumbar spine furthermore, so we have on the right and left side of the vertebrae, we have something called the transverse processes. So transverse processes are projections out towards the side, and alongside we have something called the superior articular process. The superior means upwards and inferior articular means downwards. So these are the articular processes. So these articular processes are placed in such a way that the superior articular process is superiorly facing, inferior articular process is inferiorly facing. So they are intermingling into each other, making a particular joint. And this joint helps in movements, and that is what we call zygapophyseal joint or the facet joint of the lumbar spine. Now these facet joint at the lumbar spine, along with the spinous process and transverse processes, are the main projections that come out of the spine along with the pedicle and lamina. So these are the general anatomical aspects which we need to actually palpate when we will be looking into the surface anatomy of lumbar spine. So this ring-shaped structure, including all the pedicles, lamina, transverse processes, facet joints, also called zygapophyseal joints, in all the 5 lumbar segments make up the lumbar spinal segment that has a lordotic curvature. Now talking about the movements available at the lumbar spine, we have something called flexion and extension at the lumbar spine, that is in the sagittal plane and mediolateral axis. Okay. Now when flexion and extension are happening in the sagittal plane, that means this is the sagittal plane, okay, and this is flexion and this is extension happening around the mediolateral axis. Okay. Now talking about the other movement that is available at the lumbar spine, we have sideward and sideward bending, that is lateral flexion. Third last movement is turning and turning, so rotation at the lumbar segment. So can you people tell me how much is the amount of flexion and extension available at the lumbar segment? Because I want it to be a totally interactive session. I want you people to interact. So please tell, how much is the amount of lumbar rotation and flexion along with the extension available at the lumbar spinal segment? Yes, and yeah, very good. Answers are coming. I'm waiting. Lumbar flexion extension. How much is the lumbar flexion extension? Yes. Very good. Perfect. So, talking about the lumbar flexion and extension, we have 40 to 60 degrees of flexion and almost 15 to 25 degrees of extension. It varies between individuals, varies with age, and varies with other characteristics of everyone varies in different things. So along with that, talking about the lateral flexion, that is around 40 degrees, and then the rotation, that is 15 to 20 degrees again. Now coming to the most important part. Now this was the general anatomy, biomechanics, and you people are well versed with it, and now you are ready to understand the main aspect of this lumbar spine. So yes, now we will be talking about what to do, how to engage the patient, what to work, how to observe, how to assess. Yes. So in assessment, I'll not be discussing the complete, history taking and that. I presume that you must be knowing that, but taking a overview of that thing, you should be asking the name of the patient, his age, gender, height, weight, dominant hand or dominant leg, along with his address, so that you can, carry up with the future proceedings, future sessions. So this was the general, data that everyone should take. Along with that, you should be talking about the history. that if someone says I have a pain in the lower back, lumbar spine, so they'll be complaining of, like, chief complaint will not be like I have pain in the lumbar spine. They'll be saying, doctor, I have pain in the lower back. It hurts sometimes when I do some movement, or they'll say it hurts when I sit, it hurts when I walk. So you should be very much vigilant there, because your history will be telling you partly that what the issue is. Yes, afterwards, so this was the history that the patient told you what is happening right now. So that was the present history. What happened in the past that led to this thing, that is the past history. Then any surgery he might have undergone, that is a surgical history. Any medicine he would be taking is the medicinal history or medical history, along with any blood pressure, thyroid problems, that is hyper or hypothyroid, hypertension, then diabetes. All these are medical issues that comes in a medical history. Then is any social history, how interactive the patient is, how much he has a social group, how many friends do he or she has. Along with that comes the personal history. Does the patient engage in smoking or alcohol or tobacco or opium, any drugs? So their behavior decide their treatment. So this is the history component that you should be knowing very well. So give that patient the time to, you should be discovering out from the patient the things which he knows, which he is telling you. Now comes the, so this was the history. Then talking about the pain. So pain can be, you will be asking about the aggravating factors, what the pain gets aggravated, with what the pain gets aggravated. And then there would be some relieving factors as well. What things make the pain better? So these were the relieving factors. Now, yeah, so the pain has a diurnal variation. Is it more in the morning or more in the evening? Because more in the morning means there's something to do with the disc. Sometimes what happens is, if the person complains of pain in the morning, that means what happens, the overnight the patient was sleeping, and what happened, because at the time of sleeping there is no compression happening at the disc. So what happens is, the disc imbibes fluid, it gets bulged, so it gets swollen, completely full of fluid in morning when the patient gets up. So because the disc is completely full of fluid, and now it pinches the nerve, because the disc was bulged, there was a prolapse intervertebral disc earlier as well, and the fluid got collected and it got big in size, and it starts piercing the nerve, touching it. So that leads to more pain in the morning. Whereas if a person complains of pain in the evening, that means he or she might be complaining of something, the pain, it was better in the morning, but as the day passed off, the pain become worse. That means a pain that has something to do with mechanical issues. So the pain increase with loading or work. So that is mechanical back pain. So these things you will be ruling out from the time of pain that's happening. Then the patient, you will be asking which position aggravates. So how does aggravating factors help you? So with aggravating factors, we mean that you should be asking that if the patient says he has more pain in sitting, that means is sitting, what happens is the intradiscal pressure increases. So the disc pressure, when it increases, where will the disc go? The disc doesn't move forward. It has very less space available forward. So what it does, it goes backwards inside the spinal canal and touches the nerve roots. So that means in sitting, when the intra-abdominal and the intradiscal pressure increases, it pushes the disc back. So the patient who's complaining that I have more pain while sitting, that means disc might be involved. On the other hand, if a patient is saying that I have more pain while standing, that means his hamstring might be tight. Okay, let's say a person comes to you, he says I am a guard, okay, in a hotel, and I have to stand there for 6 hours daily or 8 hours daily, and whenever I stand I get a sharp pain in in the lower back. So I would be presuming, yeah, there might be something to do with his or her hamstring muscle that might be tight, that might be leading to this pain, because that is tight, that's pulling the pelvis backwards, and that is leading to this pain. Now if the patient says, I have more pain while walking, so in walking what happens is, so the person while sitting was like this, the lumbar spine was like this. While walking, the lordosis increased because of the walking stress, and that led to compression at the facet joint, because facet joint gets closer while walking, and that led to more pain while walking. Okay, so sitting, standing, walking. Now one patient comes to you, he says, I'm okay while standing, I'm good while sitting, I'm good while walking as well, but whenever I lie down, I get a pain. So how can you rule out that thing? So while lying down, what happens is, if the patient has increased lordosis at the lumbar spine, so if he is lying with legs straight, the lordosis further increases, okay, and that leads to compression on the facet joint, and that leads to increased pain while lying down. So what is the thing is, you will just see if the curvature is more or less. So we'll be coming to that in the next thing. So then you will be assessing the pain behavior. How is it constant? Is it intermittent? It comes sometime, or is it episodic? It comes with a certain activity and goes away with other, that way, right? And if the pain is radiating or non-radiating, because the whole story changes. A disc that protruded backward was just, it was not just touching anything, so that would be just a pain because of the disc, so we might call it discitis, okay. But as soon as the disc touches the nerve, it starts paining along the nerve root towards the foot as well, towards the back side of leg. It gives symptoms of sciatica. So that means the story changes. Now the disc nucleus pulposus that came out, now it's touching the nerve root, and that's going through the whole root of the nerve, and that gives pain along the complete course of the nerve. So, and last but not the least, in the history taking and pain assessment, you will be asking about the intensity of the pain. So how to ask about that? You will be asking the patient that when you get pain, how severe is it? Like your pain, if I tell you there's a scale from 0 to 10, how much will you mark your pain? 0 means no pain at all, and 10 means the severe most pain you have ever experienced, right? So these things, then you move on to the next part of the assessment of a patient with lumbar spine, and you have something called observation. So observation although starts just before the history as well as soon as the patient enters your clinic. The way he is walking, he might be having some tilt to one side, some scoliotic curvature, okay, so like this and this, okay. Along with it, he might be having something called list. List means, here was a disc, so I'm standing like this, inside is my disc, right? Disc went out, it compressed the nerve on the left side. Now to relieve the pressure on the left side, what I'll do is, I'll bend forward, pressure relieved, but still left side is being compressed. Now I'll move to this side. Now this position will lead to ultimate relief in pain, and I'll feel much relieved. But this condition, in this position, this posture will lead to issues afterwards. So this is what we call list. So we need to observe this thing as well. So these things comes under observation. Then local observation will, you'll see that is there redness, swelling, any inflammatory or spasm thing that's visibly there. You will take out those things, right? Then comes your palpation. Now the main thing comes into action. Along with palpation, we'll be discussing 2-3 things. So we'll be discussing about the musculature around that area, that how does that gets affected, and how can that affect the movement at that particular part, how we judge the area, how we mark the surface marking, and how we go with the treatment. Alright, so for the assessment part, I would like to call someone. Alright, so on the lumbar spine, whenever we are assessing, we will be assessing first in standing. The palpation component should be first done in standing, then in lying down. Generally, what we do is we just make the patient lie prone on their stomach, and then we assess the lumbar spine, we mark the things. But why we should do in standing? Because in standing, the muscles are working against gravity, and that is what we actually want. We want to see how the muscles are working, and if there is a issue in standing, so it is what we call functional assessment. Along with the functional assessment, this is what we call palpation of the in the functional position, because when the patient will be coming to you, he will not be complaining that only he gets pain while lying prone. He would be getting the pain in standing. So why not the assessment should be in standing as well, right? So for that thing, you should be knowing which all structures are there, right? So if we see here, if we go a bit deeper over here, this is what we call the iliac crest. So this one, although it's curved like this, I have marked the upper surface. So this is the iliac crest on this side, and likewise go a bit deeper here, and this is the iliac crest this side. Okay. Now this iliac crest comes like this, and here, and likewise on this side it goes like this. On both the sides of the spine, we have something called PSIS. Okay. So here deeper, we got this PSIS. So this is the PSIS, okay, posterior superior iliac spine. So now, as a rule of thumb, we have something called S2 vertebrae, sacral 2 vertebrae in between these two dimple of Venus or the PSIS. So these PSIS are also called the dimple of Venus. They are two depressions that lie above it. Those we call dimple of Venus. We can directly see it, we can directly palpate it, and we can directly mark it. In between these two, there is if you draw a straight line here, you will see this is the S2 vertebrae. The spinous process of S2 vertebrae lies here. Okay. Now, just moving up, you will see L5, L4, L3, L2, and L1. Okay. So these 5 lumbar vertebrae. Alright. So these vertebrae, now what you can see in this standing movement, the standing position, what you can palpate is, you need to see are the PSIS at same level or not. Why? Because what happens, if a patient has back pain and you assess the PSIS, you got to know one PSIS is higher and the other is lower. So the patient is standing straight and this, let's go for painkiller. So this is a bit lower, right? So that means, see, this is higher and the other PSIS is lower. That means the right leg of the patient might be shorter than the left leg. That means because of the short leg, the patient was standing with a tilted pelvis. Okay. Second thing, if there is an overactivity of the Quadratus lumborum or Latissimus dorsi muscle, because both of them attach on the iliac crest. So here is the attachment of Quadratus lumborum till here, right? So this is the Quadratus lumborum muscle. Okay. And here as well, from the iliac crest up towards the shoulder goes the Latissimus dorsi muscle. So both the muscles, because they attach here, so if they have an overactivity or something, they'll lead to upward movement of the pelvis. So you'll see the PSIS is a bit higher on this side. So this way you can palpate the Quadratus lumborum muscle, the Latissimus dorsi muscle, the PSIS, the iliac crest upper borders, and you can see whether they are in alignment or not. If one of the pelvis is rotated forward, the upper body is straight, and the pelvis is rotated forward because of pain. So that will also, you can easily see that one PSI is in position, the other one is rotated forward. So that means there is some issue. So this was what we need to see in the standing palpatory aspect. Now coming to the sitting and lying one actually. Okay, so coming to the lying one, we have, right, so with the patient in prone lying position, what all things we need to take care of? First and foremost, the patient can either keep his or her hand by the side or he or she can take it forward. So for right now, we are placing the patient's hand forward for sake of convenience. Now, if you see here, I have just zoomed out this thing so that you can easily make out what's happening around. So these are two depressions here. So these two depressions we call the dimple of Venus. Okay. So this is one dimple of Venus, okay, and this is another dimple of Venus. If we press it, we will find there are two PSIs, as I mentioned in the standing position. So these are the two PSIs, that is posterior superior iliac spine of the iliac crest. Just upwards here, you feel that is the crest of the ilium, that is this curved area. So this is what we call the crest of the ilium here. And on this side again we have this crest of ilium, okay. So I marked them as a straight line, although they are curved like this, they go like this. So I marked the uppermost edge. So this is the crest of ilium, okay, on both the sides. Now this crest of ilium, if we extend it to the midline, this is the L4. So this is the L4 vertebrae, okay. And in between the PSIs, in between the right and the left PSIs, we have the spinous process of S2 vertebrae. So in the midline we have the spinous processes. On the sides, on both the sides we have the facet joints, and further going from the facet joints to further laterally we have the transverse processes. So these two iliac crest, and in between the L4 vertebrae, these two PSIs and the S2 vertebrae. So here is the S1 and here is the L5. So here we have something called L5 vertebrae, okay. So L5, L4, then likewise you have L3, L2 and L1, okay. So I'll mark the L4 here. Then we have L3. So here's the L3. Then I'll go a bit up and I'll see the another pointing structure, that is the spinous process of L2. And then I'll go a bit more up and here's the spinous process of L1. So 1, 2, 3, 4, 5. Then we have this S1 and this S2, okay. So sacrum ones are closer because they are more or less fused. The lumbar ones, if you see, you have two ways of palpating the lumbar spinous processes. Either you go downside up or you can go upside down. So the way I discussed with you is the downside up. Like first you palpate either the iliac crest or the PSIS. If you will palpate the PSIS, you will come to a point called S2. From S2, then S1, L5, L4, 3, 2, 1. Or else you can come in between the two this iliac crest, and you will come at a point called L4, then L3, 2, 1. So the rule of thumb is there is a pointed structure, in between there is a space, and then again a pointed. So pointed structure, space, pointed, space, pointed, space and pointed. Space is the intervertebral space. So there is a space between the two vertebrae. So you will feel it. So if you have your family member or friend sitting beside you, you can just palpate this thing on him or her, that yes, there is a bulging out structure, the spinous process. Then there is in between there is a space where there is nothing. Then again there is another spinal process, okay. Now this was a central line. Now coming to the lateral aspects of this, one thumb laterally. So almost here we have the facet joints of all these structures. So let's say for the L1 and L2, the facet joint will be somewhere near this space. So here's the facet joint. So facet joint is the joint made between the superior and inferior articular surface of the two bones. Then for the L2 and L3 we have this facet joint. For L3 and L4 we have this one, and for L4 and L5 we have something here. Now we move a bit more laterally. Here we have the transverse processes. Okay, so likewise here transverse process for 1, then 2, then 3, 4, 5. Likewise, okay. So just moving one thumb laterally is the facet joint. Moving 1.5 thumb laterally is the what? The transverse processes. So this was downside up approach. So now if you want to go upside down approach from the thoracic spine to the sacrum, then what you need to do is you need to palpate the rib. So the 12th rib, you go deeper, you feel it. Here's the 12th rib. You should be very much cautious. Then whenever you are touching the patient, first and foremost you should be taking his or her consent. Second, you should not be pressing it very hard, otherwise the patient may get more pain and he or she will not be coming to your clinic ever again, I'm telling you. So that thing you should be well vigilant about. You should not be palpating with a thumb because that gives more pressure as compared to fingers. So better use your fingers because it's more of a muscular and vascular. These areas you have stomach, spleen, kidneys and all. So you should be very gently palpating these structures. So going deeply. So here's the 12th rib. So this is the 12th rib boundary. Okay. So 12th rib is going like this, and yeah, it's going up like this. So 12th rib is going up this way. So this is the 12th rib. Okay. And you should not be pressing very tightly. The patient may get tingling. Okay. So he'll be moving and the surface marking can get a bit disturbed. So here's the 12th rib, and 12th rib attaches on the 12th vertebrae. So here's the T12 vertebrae. Okay. So that way T12, then again in between there is a space, then there is a L1, then space, then L2, likewise moving downwards. So either upside down or downside up approach. So this way you can palpate the lumbar spinal structures. Now, if talking about the muscular structure, as we discussed in the standing as well, we'll be palpating and we'll be taking out the structure. So before that, for palpating any sort of, let's say in elderly patients, what we generally see, there are osteoporotic stress fractures in the these spinal processes or spinal joints, vertebral joints of the lumbar spine. So how to assess them? You just need to percuss them. Tap tap, tap tap, tap tap, tap tap and tap tap. You know all the structures, you know all the surface markings. Now you can easily just tap tap and get the result. You can get to know what the issue is. Now if you want to see the joint play at the lumbar vertebrae, what you need to do is you need to use your pisiform bone, the ball of the foot, ball of your hand. So pisiform is called the ball of the hand. So what you will do is, let's say I need to assess the movement at the L2, so the joint play at the lumbar 2 segment. So I'll come to the L2. So what I'll do is I'll palpate the here's the 12th rib. I came to T12. Now this space is there. Then we have L1. Then we have the space. Then L2. Okay. We came over L2. Here's the L2 thing. Now I place my pisiform on this. Now, so this is, you might have seen, those kung fu karate things. Okay. So they place their hands like this. So this is a kung fu approach. And then this is what we call chopping it off. So we opened it, we placed our hand like this. Okay, so this straight, pisiform on the L2, this one opening and placing it here. This this palm area on this, you are standing straight alongside the patient and with your body weight, with your arms relaxed, with your hands relaxed, you will be pressing down with the body weight and assessing the joint play at L2. 1, 2, 3, 4, 5. Yeah, it's normal. Then L3. 1, 2, 3, 4, 5. Then leaving a space. Then again next L4. We have 1, 2, 3, 4, 5. And this way down and up. And if you want to see if, so this was the central anteroposterior pressure. for assessing the joint play. How about the lateral facet joints? They are also joints. So we need to assess the, the unilateral anterior-posterior joint play. So for the facet joint. So what we'll do, we know, yes, in between L1 and L2, if we move laterally, just we'll place our thumb like this. We'll place it like this. So we are one thumb apart from the lumbar vertebrae. And now here is the lumbar 1 and 2 segment facet joint. So we'll place our pisiform here. We'll place our hand like this. And we'll assess it like this. Okay, 1, 2, 3, 4, 5. Perfect. Moving down. 1, 2, 3, 4, 5. So this way I'll be assessing the complete spine. Okay. Now you are well versed with how to proceed with the lumbar spine and how to proceed with the movement and joint play. How to see how the movement is happening against gravity and in all those positions. Now there is a condition. What happens is sometimes the lordosis is so much heightened in some patients. Then what happens is, if let's say if this patient has a heightened lordosis, so see this curvature increased. So now, so it is the spinal process of L2 and it is of L3. These were distance. When the patient was normal, it was normal. Okay. So these were at a distance. Now when the lordosis increased, like this, so these spinous processes came together like this. So now it's a bit difficult for you to palpate these two spinous processes. So how to proceed with such a patient? So for such a patient, what you need to do is make them sit in an alternate position, and that is sit up with your knees bent, like I'm sitting. Yeah, and so this position with the knees bent and bending forward, both your arms forward. Yeah, so in this position, what happened is there is a separation of both the iliac crest, separation of the SI joint, right? Along with that, these. Alright, so now as we very rightly discussed the discussion component this of palpation of the lumbar spine. Now you are well versed with all the things now. I believe that is perfectly fit in your brain. Now moving on to the next part. So after palpation comes the examination component. That's very wide enough, but yes, I'll cut short that and will give you a crux of that thing. So you will be assessing the active range of motion of the lumbar spine. As we discussed, there are certain degrees of movement in flexion and extension. So how will you be discussing? How will you be assessing? So you will tell the patient to go in flexion. So in flexion, both his hands should go like this and relaxed. So first his neck will move downwards, then his body will move downwards like this. Okay. Then extension. In extension, both the hands will be kept at the pelvis and go backwards. So what you will be telling the patient is that you need to look at an object in front of you. You should not be going like this, because this apparently increases the active range of motion. So keep your hand at the pelvis and looking forward, go like this. So this is the actual extension range of motion at the lumbar spine. Now for turning and rotations, you will ask the patient to come cross arm, sit cross arm, and then turn to one side and then turn to opposite side. Then lateral flexion towards this and towards this, right? Both the sides. Now next comes so this was the active movement, then comes the passive movement. In passive movement, you will make the patient do all these activities. Then after that comes the movement in which you give overpressure. So let's say if the patient performing flexion, he is not having pain, so you give him overpressure. You press him a bit more down and you see if the pain aggravates or not. So if overpressure aggravates the pain, that means there is some issue with the extensor structures while flexion, or the issue with the flexor mechanism of the abdominals while extension. So that should be taken care of. Then comes the repeated movements and combined activities. So repeated movements. So flexing for a single repetition might not aggravate the patient's pain. But if you tell the patient that you bend 10 times forward, 1, 2, 3. That way 10, 15 times, what happens is the patient pain aggravates. So that means there is an issue with the endurance of the muscles rather than the strength. Strength is okay, he is able to do the movement once. But when it comes to repeated movement forward and backward, he is not able to do. That means there is some issue with the endurance. Now come the repeated movements. So this was the repeated movements. Now the combined movements. So combined movement mean, so the normal movement is flexion or extension or sideward bending or rotation. Now combined means combination of any two of these or any three of these. So let's say if the patient is not having pain in flexion extension, over pressure in resisted movement, no pain is there. Okay, now you will come to combined movements. What to do? Flex, rotate, further flex. Okay, this movement might be giving pain. That means flexion with sideward rotation to the right is giving pain. That means there is an issue inside the right side of the structure, lumbar spine. If the patient gets pain turning and bending towards the left, that means issue is there in the left side of the lumbar spine. Now the person comes and you tell him to do extension and rotation. That means, and the pain comes, that means it's on the right side of the lumbar spine. And if the patient says, then when I go back and turn to one side, I feel ease. That means, then extension means easing of the pressure from this side, and then going to this side means further easing of this pressure. So right side is being eased off. So there might be the thing that forward flexion and rotation to the right might increase the pain, and backward flexion, that means extension, and rotation to the left might decrease the pain on the right side. So that means it is confirmed that this side has the issue and what to do to counter that thing. So this was about the combined movement. And last but not the least, when all these things are covered, you come to the MRI, X-ray, CT scan, CAT scan, PET scan, anything. These things are just, comes in the last. You should not be relying on an X-ray. You should not be looking for an MRI. You should be well versed with these physical examinations. Let the physician do the physician thing. Let the orthopedic do the orthopedic thing. You are a physical therapist. You have got those magical hands. You need to utilize them. You need to work with them actually, You need, once you are able to do what you are supposed to do, nobody will be able to, question you about anything, because you will be the master of your basics. Then your advanced will be in your way and you will be perfect. So that with these words, I would like to conclude here. There are many concepts which are still left in the lumbar spine assessment and rehabilitation, because lumbar spine is a big area and back pain has got a number of domains. If you people wish to see more of such things, you can just stay connected with us and let us know in the comment section what all you want apart from this, what all topics you want discussions on. So I will just hand on the further proceedings to Dr. Karishma Chawla. She'll be discussing the sacral palpation and the sacral assessment component. So stay tuned, take care, see you. Goodbye.